Welcome to this video on pneumonia. Pneumonia is basically inflammation of the alveoli due to infectious agent. Inflammatory induration of normally aerated lung due to presence of cellular exudative material in alveoli is consolidation. How does pneumonia develop? Most likely occur pneumonia due to immune system weak and organism is very strong and body fails to filter the organism. Factors that are predisposing are cigarette smoking, upper respiratory tract infection, alcohol, corticosteroid therapy, old age, and recent influenza infection, and pre-existing lung disease. Reduced host defense due to diabetes, malignancy, pregnancy, and reduced mucociliary clearance, and reduced cough reflex due to post-operative conditions. And factors predisposing aspiration of nasopharyngeal or gastric secretions due to immobility or reduced conscious level, vomiting, dysphagia, achalasia, or severe reflection, gastric intubation. Bacteria introduced into lower respiratory tract due to endotracheal intubation or tracheostomy, infected ventilator or dental or sinus infection. Other factors are bacteremia, abdominal sepsis, intravenous cannula infection, and infected emboli. Congestion is presence of proteinaceous exudate and often of bacteria in the alveoli. Radiobetization, presence of RBC in the cellular intraalveolar exudate. Neutrophils are also present. Bacteria are occasionally seen in the cultures of alveolar specimen. Gray hepatization, no new erythrocytes are exudating, and those already present have seen lysed and degraded. Neutrophil is predominant and fibrin deposition occur. Resolution phase is macrophage is predominant in the alveolar space. The debris of neutrophils and bacteria and fibrin is seen. Anatomical classification include bronchopneumonia is affecting the lungs patches around the bronchi. Lobar is infection of the single lobar section or section of the lobe. Interstitial pneumonia involves areas in between the alveoli. Clinical classification, community acquired, typical, atypical, or aspiration, pneumonia in elderly or nosocomial hospital acquired pneumonia in immunocompromised. Community acquired is infection of pulmonary parenchyma associated with acute features of infection and presence of AC infiltrate on X-ray or auscultatory findings suggest with pneumonia. Hospital acquired that occur 48 hours or more after admission. Ventilator 48 to 72 hours after endotracheal intubation. Healthcare associated pneumonia include any patient who was hospitalized in acute care hospital for 2 or more days within 90 days of infection. Atypical pneumonia clinically subacute onset fever, less common or less intense and minimal sputum. Microbiologically, sputum doesn't reveal any prominent microbiological etiology on protein smears like Gram stain or Gene Nielsen or culture. Atypical organisms are Mycoplasma pneumonia in 14% of all cases of hospital pneumonia in children, and Legionella and Chlamydia 9% of hospitalized pneumonia in children, Coxiella burnetii. Atypical pneumonia radiologically patchy infiltrates or interstitial pattern. Hemogram shows peripheral leukocytosis are less common or intense. Aspiration pneumonia, overt episode of aspiration or bronchial obstruction by a foreign body, seen in alcoholism, nocturnal esophageal reflux, or prolonged session in the dental chair or epilepsy, and usually of anaerobes. Elderly, infection has more gradual onset with less fever and cough, often with a decline in mental status or confusion and generalized weakness, often with less readily elicited signs of consolidation. Etiology of this pneumonia includes Streptococcus pneumonia, most common 40 to 70%, viruses 10 to 36%. In India, Streptococcus pneumonia, Staph aureus, Klebsiella pneumonia, and Haemophilus influenza, Mycoplasma, Legionella are common. No extrapulmonary features are typical bacterial pneumonia. Extrapulmonary features with zoonotic contact history, psittacosis, flu, fever, and tularemia, and without zoonotic contact history, Mycoplasma, Chlamydia, and Legionella. General symptoms include high-grade fever, cough, productive and pleuritic chest pain, and breathlessness. Additional symptoms include sharp or stabbing pain, and headache, and excessive sweating, and clammy skin, and loss of appetite and fatigue, and confusion, elderly, especially in elderly people. General signs are fever, tachypnea, tachycardia, cyanosis central, and hypotension and altered sensorium. These are accessory muscles of respiration, and confusion in advanced cases. Signs of consolidation include percussion, there is dull sound, and the bronchial breath sounds, crackles, and increased vocal firmness and resonance, and egophony. And sputum shows gram staining, AFB, and GIMSA, and KOH, and culture. X-ray shows homogeneous opacity with air bronchogram in case of consolidation, and lobar pneumonia peripheral air space consolidation. This is right upper lobe pneumonia. This is right lower lobe pneumonia consolidation. Bronchopneumonia, centrilobular and peribronchial opacity pneumonia tends to be multifocal and patchy in distribution rather than localized to any one lung region. Interstitial is peribronchial infiltrate mycoplasma and viral causes. Investigations in pneumonia, complete blood count and blood sugar, electrolytes, urea, creatinine, and blood culture, and screening of retrovirus and oxygen saturation by pulse oximetry, ABG, ultrasound test, and Mantoux test. Invasive bronchoscopy, thoracoscopy, percutaneous aspiration, open lung biopsy, and pleural aspiration. Other tests like bacterial antigen in sputum and urine, rapid viral antigen detection test, and outpatient treatment is empirical. Previously healthy and no antibiotic received in last 3 months, a macrolide like clarithromycin or azithromycin or doxycycline, comorbidities or antibiotics in past 3 months, we give respiratory fluoroquinolones like moxifloxacin, levofloxacin, or beta-lactam, high dose amoxicillin, amoxiclav. In patients who are on a non-ICU, a respiratory fluoroquinolone like moxifloxacin, levofloxacin, beta-lactams like cefotaxime, ceftriaxone, ampicillin, plus a macrolide like oral clarithromycin or azithromycin. In patients and ICU, beta-lactam plus azithromycin or fluoroquinolone. Asthma pathogens include genetic factors like HLA gene mutation, defects in bronchial or bronchial epithelium, and environmental excess hygiene, fewer siblings, antibiotics within first 2 years, atopy, predisposition to allergy, hypersensitivity in airways, and the first exposure to trigger sensitized helper T cells, stimulation of B cells to produce IgE, which binds to mast cell surface, activated helper T cells and IgE sensitized mast cells now line the airway. Secondary exposure to triggers will cause early response and delayed response. Early response is IgE mediated, where mast cells release histamines, leukotrienes, and other inflammatory mediators, which will cause vascular permeability increases and goblet cell hyperplasia and bronchial or smooth muscle contraction, which will result in airway obstruction, causing asthma. Delayed response 3 to 4 hours, activated mast cells and helper T cells release the cytokines. Induced maturation of granular WBC like eosinophils, and eosinophil will migrate into airways, will cause bronchoconstriction, eyes will cause conjunctivitis, and nose will cause rhinitis. Scoring system for step care management in case of asthma. Darkas criteria predicted to 7 to 0. So, where do you have dyspnea every day? If it is yes, score is step 0, or no, score is 0. Management is step 1. Do you have nocturnal attack of dyspnea more than 2 times per month? If it is yes, 1, no is 0. Score is 2. Score is 1 and step is 2. Do you have suffered dyspnea attacks with severe enough to cause necessitate steroid tablet, nebulizer therapy, aminophylline injection, or hospital admission? If it is yes, score is 2 and step of management is 3. 2 and 3 include 3 includes score 3 include 4A management. Do you have persistent dyspnea for last 6 months or more, or are you taking steroid tablets for 1 year or more? If it is yes, score is 3 and step of management is 4B. Is the patient baseline? If the patient's baseline during asymptomatic stage PEFR is less than 60% of predicted value, score is 5 to 7 and step of management is 5 or 6. Predicted score is 7 to 0, right? So short acting beta agonist like salbutamol in step 1 management, which is intermittent asthma, persistent asthma where daily medication is needed. Step 2 is low dose inhaled corticosteroid. Alternate include theophylline, chromoglycolate. And step 3 is low dose inhaled corticosteroid plus long acting beta agonist or medium dose inhaled corticosteroid. Alternative include theophylline, low dose inhaled corticosteroid. Step 4, medium dose inhaled corticosteroid plus LABA, long acting beta agonist. Alternative include low dose inhaled corticosteroid or theophylline. Step 5, high dose inhaled corticosteroid plus LABA, and consider omalizumab for patients who have allergies. Step 6, high dose inhaled corticosteroid, LABA plus oral corticosteroid, and consider omalizumab who have allergies. So step 1 is for mild and intermediate attacks only. Occasional use of reliever bronchodilators like salbutamol, which is short-acting beta agonist, will relieve the symptoms. And terbutaline inhaler also we can use. Include 1 to 2 puffs, 1 to 4 times a day. Next is the second choice. The second choice would be in case of mild and intermediate asthma include tablet salbutamol or tablet theophylline or terbutaline. Step 2 is if bronchodilators fail to control the attack efficiently or if the patient has more than 3 attacks per week, we give steroid inhalers, low dose anti-inflammatory plus step 1. Option A include low dose inhaled corticosteroid, full dose of chromoglycerate or leukotriene antagonist, or sustained release theophylline, are used in step 2 management. Next is step 3. Attacks are still poorly controlled and are more frequent. We will give high dose anti-inflammatory plus supplementary leukotriene antagonist. So high dose steroid inhalers, salmeterol or formoterol, combined inhalers like salmeterol plus fluticasone, formoterol plus budesonide. So from this stage, from step 3, it should be treated by the chest physician. Step 4 is high dose inflammatory, anti-inflammatory plus regular use of protectors and combined with step 3. And step 4 and step 5, where high dose inhaled corticosteroid, long acting beta agonist, and theophylline and leukotriene antagonist are given in step 5. Addition of oral steroid in step 6. What are the investigations we do in asthma? CBC, WBC, ESR, eosinophil count, and blood sugar, urea creatinine, X-ray change, PFT. Treatment of acute attack include acid inhaler, which contains salmeterol, 1 to 2 puffs to be taken by the patient at the onset of attacks. Injection terifilin 2 cc IM or IV, or injection terbutaline IM. If patient is young, give injection adrenaline 0.5 ml subcutaneous, isoprenylin auto inhaler 1 to 2 puffs. If attack is severe, oxygen by the nasal catheter, aminophylline injection 500 mg in 10 ml vial, diluted with 10 ml of 25% of glucose IV solution, slowly given over 4 to 5 minutes. Nebulization with acetylene or urine solution, STAT and SOS. If attack is not relieved with aminophylline, repeat aminophylline 500 mg, IV after 10 minutes. Injection hydrocortisone or decadron or prednisone 40 mg, IV start is given. Oxygen by the nasal catheter. Refer the patient to hospital. And clinical judgment, how we judge clinically, mild attack, these are bronchi only. Moderate retraction of intercostal spaces will be there. Severe retraction of intercostal spaces along with cyanosis, poor capillary refilling, altered sensoria. These cases require oxygen. Thank you.
Rise, young warrior. You must get up. Your journey is not over.
I can't fight him. He has all my weapons. I have nothing.
When you began your journey, you were determined. Nothing could stop you. And now that you are so close, are you willing to give up so easily?
It was easier at the beginning.
Beginnings are often easier. But think of all that you have accomplished along your journey. What you have learned from your battles with the bear, the snake, the monkey.
What's the point of fighting my way up the mountain when someone else is just going to come up the easy way?
There is always going to be someone who does things the easy way. But that should not stop you from doing things the right way. It is your journey, young warrior. Only you decide when it ends.